All right, I think we have enough people to call our meeting to order here today. Welcome to the February board meeting of the Board of Health, Spokane Regional Health District. We'll go ahead and start with roll. We'll start with
Mary Cuney, Spokane County Commissioner.
Amelia Clark, Administrative Officer of the Health District.
Bob Lutzs, County Health Officer.
Jason Kinley, appointed.
Josh Kern, Spokane County Commissioner.
Andrea Frosthead.
Ann Pitzel, Recording Secretary. Michelle Fossum, Legal Counsel.
Linda Thompson, City of Spokane Valley.
and Ben Wick from the City of Spokane Valley and Chair. All right, next up on our agenda is citizen input. And first on our citizen input, which I guess I don't have to read some rules here, but it's to please limit to 3 minutes before speaking to the board and come up to the microphone. And the first one up is Jackie Gallagher. That's right, and our Vice Chair, Commissioner Cooney, is the timekeeper today.
Hello, my name is Jacqueline Gallagher. I first attended a meeting, this is my 3-year anniversary with you. Faces have changed, but the issues have not. I first attended a meeting to try to remedy the improper exclusion of my son from school during the Marshallese mumps outbreak. During that episode, the Spokane Regional Health District disguised the facts around that 80% of all infections were in fully vaccinated Marshallese students. This outbreak was spread nationally throughout the Marshallese members. Instead of excluding those students who spread and contract mumps, regardless of vaccination status, they left them in schools, guaranteeing that there would be cases. Instead of kicking the Marshallese out or simply telling their associates with an information letter like we have had until that year, the outbreak was used as a way to harass exempting families. When we came to the meetings, and the board understood the exempting families were no part of the outbreak, that the schools were completely unprepared to support students, and this improper exclusions were causing real harm to students, you tried to intervene and asked that the involuntary exclusions be lifted. There was even a special meeting on St. Patrick's Day to discuss this, and this meeting had no parents or students on the agenda. It was a dog and pony show to disguise the real fact about the exclusion that the staff at Spokane Regional Health District didn't want you on the board to know. That the exclusions were not mandatory. We were free to attend school. You didn't need a special meeting. So the staff here either broke the law by enforcing mandatory exclusions of illegal length without proper notification of rights to challenge and other violations of the isolation and quarantine laws, or they fraudulently misrepresented a voluntary exclusion to mandatory in a public records request. We learned that the Spokane Regional Health District staff used a test negative mumps case to illegally extend an already illegal exclusion, which you have in front of you. Did anyone get fired, disciplined in any way? No, they probably received a bonus. These illegal exclusions were not simply inconvenient. One of the excluded students perished by suicide, and it is very probable that the exclusion exasperated this boy's distress and probably outright provoked it. I have repeatedly asked the Department of Health for their research on the safety of excluding a child from school and the chance of provoking a self-harm attempt. They have not responded in 2.5 years. The state and district have a legal duty to notify parents of the psychological, emotional, and social damage of exclusions and the risk of provoking a self-harm attempt. My presence here is to try to bring some sanity to an out-of-control, reckless pursuit of vaccination rates at all costs, regardless of the damage caused to the excluded students. These actions are no different than any other hateful discrimination that history has seen. Thank you.
Thank you. Next, we'll have Lindsey Donahue.
I brought a little show and tell. I don't know if that's allowed. Okay. Are we ready? Okay. My name is Lindsey Donahue. I'm a naturopathic physician, and I strongly believe in the precautionary principle. I'm speaking about 5G today, and I believe that if Spokane County put health and living near nature as a priority, the people in position would stop the rollout of 5G, or at minimum restrict 5G to downtown only. Small cell antennae are the same as on the macro towers. It's not that different of a technology. However, instead of being 100 feet in the air, these small cells will be several feet from a bedroom window, and there will be more of them. EMR biological effects have been well documented and ignored. Life, we're bioelectric. There's a whole book about it, and it's well documented in this excellent book. The dangers of electropollution are real. I've got a little bit, but I'm going to skip that. Microwave, radio waves, and ELF can cause a decline in red blood cell count, hemoglobin concentration, hence oxygen carrying capacity. Changes in carbohydrate metabolism have been noted. Cancer rates continue to increase. Infertility is increasing. Magnetic fields of 0.2 to 4 Gauss, vibrating at 10 to 4,000 hertz, enhance replication of DNA during S-phase mitosis. A rat study looking at 50 to 5,000 microwatts over only 1 to 10 days showed chromosomal defects in astounding numbers. Just 50 years ago, overall cancer incidence was 1 in 12. Now it's nearing 1 in 2. Dr. Robert Becker, who actually wrote this book, he's a pioneer in the area, he is expecting that we might see a time when everyone experiences 2 or more unrelated cancer incidences in their lifetime. Clearly, something is turning our DNA on and off in an abnormal way. Non-ionizing radiation is an air pollution. It should be regulated, but energy modalities are not like other traditional toxin models. Energy modalities are non-linear. We may discover that some exposures are unsafe at any intensity. We've barely begun to investigate man-made EMF effects to other species, but consider this. Extinction rates in plants and animals have accelerated to a point never seen before. While there are many complex factors involved, increases in artificial ambient energy levels are not even part of the dialogue. 5G is and has been deployed in Spokane because we all know that data speeds and smart cities are far more important than human health and the environment. Actions speak louder than words. The 5G rollout in Spokane is Spokane's declaration against the precautionary principle. And I've got some information. If you're interested, what you need to know about 5G wireless and small cell. And then for those big readers, I've got a little packet from physicians for safe technology, et cetera. Thanks for your time.
Thank you. And if you wanted to hand those to our clerk, I'm sure she could get them over to us. Next up, we have Colleen Palmer. Hopefully I got your name right.
Thank you for giving me the opportunity to speak. I'm a native of Spokane, but I lived in Boston for 20 years, and I'm just so pleased that we have these open forums, so thanks. So I'm here today to talk about wireless, the dangers of wireless technology, and especially here to invite any of you, anyone from the public health arena, to a forum that's being held today. I know it's short notice. It starts at 4 o'clock, and it's the Wireless and 5G Forum. This is an open, balanced forum where we will have someone from the profession, from the industry, talk about the technology and how it works. That's the first hour. And then at 5 o'clock, Dr. Martin Paul, he's a biochemist. He will be talking about how it affects our biology of all life forms on this planet. These frequencies have never been before. And it is completely counter to our biology to be increasing the exposure. This is being done without consideration for the over 1,000 studies that have showed that non-ionizing radiation affects biology. It's something that we all, I feel, must take very seriously. And the FCC currently is a bot regulating body, meaning that they refuse to look at the new science that shows that non-ionizing radiation affects biology. This is something that each and every one of us must look at because our regulating body is refusing to do so. Dr. Martin Paul has been spending his retirement traveling the world, educating the public and policymakers about these concerns. So I sincerely hope that someone from the Board of Health might be able to squeeze in at least to the 5 o'clock session today to hear from his mouth what he has discovered, a scientist, what he has discovered, and hopefully this will begin a conversation in the Board of Health, and I've also spoken to the City Council about what we can do to protect all of us, all of our citizens, from the negative health effects of this ever-proliferating technology. Thank you.
Thank you. That's all I have for sign-ups today for public comment. So we'll move down to the consent agenda. Is there anything that any member would like to set aside from the consent agenda? Go ahead.
I'd like to set aside the vouchers due to the organization I work with has a payment.
Okay. So we'll set aside the vouchers, leaving just the meeting minutes. Do I have a motion to approve the minutes?
I move to approve the minutes.
Second.
All right, moved in second. Any discussion on the minutes? Seeing none, all those in favor, please signify by saying aye.
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 All those opposed, nay. Motion is approved. Now I'll move down for the vouchers. Do we have a motion to approve the vouchers?
So I move to approve the vouchers for January 1 to January 31st, 2020.
Do I have a second? Any discussion on the vouchers? Seeing none, all those in favor, please signify by saying aye. Aye. All those opposed, nay. Abstentions? Okay.
Yay. Yes. Me.
All right, motion is approved for the vouchers. Don't have any other action items today, so we're down to the chair's report. One of the things that I know we have some new members on the chair's report, and I don't know if you wanted me to cover, so just roles and responsibilities. So we are the policy and vision and guidance for the board, and then our staff members, or Amelia through our administrative officer, is day-to-day operations. So just wanted to kind of highlight we don't get involved in the day-to-day operations as much. We get to give the policy and direction level for Amelia. I know sometimes it gets a little confusing in some of the discussions we have. Then underneath the chair, we also wanted an invite will be sent out to Board of Health members for the 2020 annual awards for the Health District and recognition program reception that is going to be held on April 23rd at 8:30 a.m. The event is to celebrate those who have dedicated years of service to the Spokane community. I think that is all I have for my report. Moving down to Board of Health committees. The Budget and Finance Committee, I don't think you guys had met yet.
We'll have our first meeting in March, so I have no information at this time for you.
Is it scheduled so far in March or not yet?
We'll be scheduled in March, and then we'll have our regular one in April.
Okay. Policy Committee? No, Brian's not here. You didn't meet either? Do you know if there's one scheduled or not? There is? Okay. Well, I'm sure they'll be reaching out soon then. Okay, no problem. And now we'll go to an administrative officer report.
So my report this time is going to be really pretty quick because I know we've got a lot of staff that are going to talk about emergency preparedness and in line with Dr. Lutz's report. So one of the things in talking with the executive committee that we're going to do, and they're going to be coming around to you momentarily here, but at the last board meeting, there was a lot of confusion over the most recent bylaws, some of the most recent resolution language, and different topics. And so with the staff's help here at the Health District, we have put together binders that we will bring down for the board meetings that you can have for quick reference if you have questions related to the bylaws, if you have questions related to a resolution. I know we'd had some discussion. There was a question about a resolution related to services. And so this will be like a living document, something that we can add to as things go on and as you vote on stuff. But remember to be mindful of your public records and public meetings training about, you're not going to want to take notes in here or things, because that would be an issue when it comes to the training that you've received. So with having said that, I think the binders have been distributed now. If you go to tab 5, one of the things I was tasked with was working on the organizational restructure here at the district, and that has actually started. And you can see in tab 5 how this aligns with what I presented to the executive committee of how we're putting together different departments to help streamline services and continue to grow and work on our strategic plan. So with that, I can answer questions related to the org structure directly. You all can reach out to me, or if you have questions related to the binders or the report. The binder information is available via the website in the same portal where you go in to get your Board of Health information. So you can see everything there too.
All right, any questions? Thank you for putting all that
Thanks.
together. Yeah. And there will be a test next month on
Yeah, quiz next month.
All right, now we're up for the health officer report. Dr. Lutz.
So once again, talking about hepatitis, respiratory issues, and others, which will be respiratory issues. So keeping you up to date on hepatitis A, we're still dealing in outbreak status. Thankfully, our numbers are down pretty significantly. You can see our numbers there, and again, as I've done in the past, and as I will continue to do, a lot of credit given to staff who have been out there vaccinating the public and really preventing this outbreak from spiraling out of control as it has. Moving on to respiratory, flu, we're still in flu season. It has not been as we have seen in the past, and certainly last year or a couple years ago. So we are starting to see a downtick, which is nice. Again, the volumes have not been as great as they have been in the past. Still primarily influenza A. And I just want to, again, you look at the numbers there locally, and I just want to give these numbers now to put my next conversation about COVID-19 into perspective. So the CDC this past week said that across the nation we've had 29 million people who have been diagnosed with influenza or influenza-like illness. We've had 280,000 hospitalizations and 16,000 deaths. And this year, in contrast to what we've seen sometimes in the past, although there was concern early on, the flu vaccine does seem to have pretty good efficacy this year. So it's estimated that right now the efficacy in adults is about 45% and in kids is about 55%, which is pretty good. We've not seen those kinds of numbers in the past. It's always sort of a mathematical model by which we determine which strains of vaccine or which strains of flu we're going to see. But as I said, this year it seems to be doing pretty well. I'll also mention pertussis. We continue to still see increasing numbers of pertussis, albeit they are tapering off, thankfully. So again, just be aware of that. So for us, it was kind of fun the other day. Yesterday we had a staff forum, all staff forum, and Amelia provided some levity and some lightness in contrast to my dourness by providing awards. And the award was given to the EPI team, and I see some of our staff EPI team here. They got the Triple Crown Award because they've essentially been dealing with 3 concurrent outbreaks, hepatitis A, pertussis, and I move on to COVID-19, otherwise known as novel coronavirus, otherwise known as SARS-CoV-2, because it's similar to the old SARS virus. This is a little outdated map, but this is a really interesting, sort of very recent map. It's updated on a daily basis from Johns Hopkins, and it provides a international picture of coronavirus 19 and how it's been affecting the world. Certainly, as you know, it's primarily been seen in China, and specifically in one province in China and one community within that province in China. But as we expected, and as you are now hearing from the CDC and from other national organizations in other nations, the spread of this to other nations is inevitable. And so the preparedness piece is really important, and that's why, as I said, I've asked Tiffany Turner to talk a little bit about that today in response to what we're doing locally. Again, the number's a little bit dated here, but as of this morning, we had 82,000 people infected. We had 2,000, what did I say? 2,000, but more than 2,000 plus deaths. And again, as we've seen, as you know, you've heard in the news, we've had now it outside of China, we have about 500 cases primarily located in northern Italy. We have cases in South Korea, where today the numbers were about 1,700. There's an outbreak, a cluster in Iran. And as of today, we had the first case in Africa, in Algiers, and we had a case in Brazil a couple days ago. So I think, the semantics around epidemic versus pandemic is just that, semantics, because we are seeing worldwide spread. And I think, again, it's really important, as we'll be discussing, the preparedness that we're encouraging people to take. Albeit, my caveat is, as I mentioned to you before, the numbers. Think about the numbers of people that have been affected by influenza, the deaths affected by influenza at the national level. Put that into perspective with the international experience of COVID. It's been suggested that right now there are 4 endemic strains of coronavirus that are circulating in the community and in the world on a yearly basis. Some estimates, again, these are mathematical models, but it's estimated that maybe 40 to 70% of the world's population will eventually be infected by this, the same way that people are infected by cold viruses. Currently, we have about a 2% mortality rate, which is not that significant. It's less than what we're seeing in some strains of flu. But nonetheless, it is of significance because it is global. I'd also suggest to you the reason that the concern exists and the way we are mobilizing the way we are is because it is novel. We fear what we don't know, and we don't know exactly all the details about this. It has been suggested that this might be the 5th endemic strain of coronavirus that we see circulating around the world. So again, sort of the way we talk about the cold and flu season, it's been said that maybe we'll be calling it the cold and flu and COVID-19 season going forward. That doesn't mean we shouldn't be prepared, but I think it needs to be put in perspective. So this is off the World Health Organization, and this just demonstrates the how we're seeing the transmission. Blue represents international conveyance, i.e. aircraft and or ships. The purple is currently international other than China and the reporting country. Again, the emphasis there is on the green bar. So essentially what you're seeing is that once this virus gets into different countries, we are seeing spread within that country. So whereas before, early on in the outbreak, we were seeing it coming from China, now in those 37 plus countries where it is spreading. And again, that's the concern. That's why we consider it a pandemic in action. You see the numbers in China going down, thankfully. As you may have heard also, I think today or yesterday, California reported the first individual who had no direct contact or indirect contact with anyone identified. So again, I think given that the continuum of presentations is from totally asymptomatic to hospitalization, we probably have a significant number of people worldwide that have already been infected but are asymptomatic and unfortunately are spreading the infection. We've been having our ICS, Incident Command System, has been activated for almost 3+ weeks, actually more than 3 weeks. So we're meeting on a daily basis and doing a lot of planning around this. Early on, as you probably heard at the international level, and as you saw in China, the real focus was on containment, i.e. can you keep the infection from spreading within and from without? Now we're looking at, given the fact that this is spreading without, how do you prevent it from spreading too much in your communities? And again, looking at mitigating efforts. And so a lot of the efforts that are coming forth from the CDC, coming forth from DOH and internally is how do you prevent the spread and or how do you lessen the spread? So these are, again, some ideas. Again, emphasize that none of these have been implemented You've probably heard of them being implemented elsewhere, certainly in China. I heard today in the Hokkaido prefect in Japan, they canceled school, all school for a month. So these are, again, some of the social distancing concepts and mitigating efforts that are being considered. Oops. And again, these are just factors that one would consider, that organizations would consider when you talk at social distancing as to what the degree of social distancing actually entails. It's not done lightly, because as you can imagine, it has significant social as well as economic impact. But some of these processes have been demonstrated to slow and or lessen the spread of the illness, and so these are all considerations. I'd suggest to you that these are considerations that are not done in a vacuum. They're done in close affiliation and close consideration with elected officials, with community members, and that's again some of the work that we've been starting about how do we have the processes in place presenting to the community to move forward if it becomes necessary. And again, the bottom line at the bottom, how do we engage local elected officials and boards to make decisions? And that's why I'm going to turn this over to Tiffany, and then we can take questions afterwards.
Hi, good afternoon. My name is Tiffany Turner. I'm the program manager here at Spokane Regional Health District for the Ready Healthcare Coalition, as well as the Public Health Preparedness and Response Program. So we've been busy lately, as you can imagine. So I just wanted to give you a brief, quick overview of some of the activities that we've been doing here within our agency in response to this outbreak. So if you haven't heard about Ready Healthcare Coalition, our team here works with over the 19 counties and 4 tribes in Eastern Washington, so working with healthcare partners to increase our healthcare system's readiness and increasing our capacity to respond. Some of the key focus areas that the Ready Healthcare Coalition is working with our healthcare partners on are assessing capacity. So the Ready Healthcare Coalition has put out a couple of surveys so far and determining what the capacity is of our healthcare facilities. So looking at what are our bed capacities for ICU beds? How many isolation rooms do we have available? Is our supplies look like for maintaining personal protective equipment over the long term. So we're gathering that information and using that to inform, kind of giving us a baseline of where we're at and how ready we are. We also do continual information sharing with our healthcare partners, so sharing like the latest guidance that's come out from CDC or from Department of Health to inform them on what actions that they can take. And we have regular newsletters that go out. We are also currently doing weekly data collection processes with our healthcare partners, primarily focusing on hospitals, to take a look at what are the impacts to your healthcare facility at this time. Where are you at with capacity in your hospital? Where are you at with supplies in your hospitals as this, outbreak continues to happen in our communities? We're going to see those impacts increase. And so using that information for what we can do to support our healthcare partners in our communities, whether that be resource request processes or helping them with some of the surge planning. So that's the other area of focus, is helping them with surge planning. So taking a look at, staff, space, and stuff. How do we increase capacity within our healthcare facilities? How do we help address staffing shortages or protecting our healthcare workers so they're able to keep providing care to the patients? And then stuff, again, how do we look at conservation methods for personal protective equipment so they have enough to provide care for our patients again. And then the last area is around coordination and resource management. So the coalition works closely with our partners to identify how we can support them and how we can coordinate efforts across our healthcare systems. So we help with, again, resource request processes. So they report to us if they have any shortages or impacts to their facilities. You'll see on the right here is the last situation report that the coalition just sent out yesterday. So again, you probably can't read it at the bottom, but it shows you that our healthcare system here locally is already having impacts just from the normal flu season. So as you can imagine, as cases of COVID start coming into our community, that's going to have even greater impacts. And so what can we do now to start mitigating some of those effects? Of course, behind the scenes, public health is also very busy. So some of the primary focus areas in public health are around sharing public information. As you know, you've probably seen a lot of the messages coming out from our communications department. So looking at how can we inform our public, how can we let them know what the risks are and how they can reduce the risk to themselves and protect themselves. Really focusing on some of our key messages that we've had, that we've been promoting throughout the years on just simple respiratory etiquette. You know, washing your hands, covering your cough, staying home when you're sick, those kinds of messages that we're always trying to promote within our communities. So using this opportunity to, again, reemphasize some of those messages. And then the other thing that we're doing is sharing guidance for specific populations. So if you'll notice on our website, we have guidance documents that are related to like schools, related to businesses, and what can we do to help support their efforts to reduce the impact within their facilities. You know, social distancing measures and mitigation measures like Dr. Lutz had referred to earlier. And then, of course, just the typical plan reviews, so pulling up the plans that we've already created and taking a look at how those plans apply to this particular outbreak and what are some of the gaps that we have that we need to start addressing and working on to strengthen our response and capability. So looking at isolation quarantine plans, which include those community mitigation measures, taking a look at fatality management plans in our community. You know, we might start seeing more deaths in our community. So luckily our medical examiner's office has just increased their capacity with their new facility. And so, but how do we work together as a community to respond to an increase in mortality? And then taking a look at other plans, like we have alternate care facility plans, we have infectious disease plans, and then really taking a look also at our internal agency continuity of operations plans. So how are we, as a health district, going to be able to maintain the public health essential services that are so important to our community? So what efforts can we make within our agency to make sure that those continue to happen? And then, of course, the daily surveillance and response. Our epidemiology department does a great job of working with healthcare providers and clinicians on a daily basis in regards to providing guidance and information on education on how they can identify cases, how they can isolate those cases, and what the reporting process is to public health. So we're aware of what the situation is, and then providing them with updated guidance that's constantly changing as far as testing and treatment. So those are some of the public health efforts happening. And then I just quickly wanted to talk about some of the ways that the Board of Health and elected officials can help support our agency in our efforts. So, of course, one of them is just being informed. So things like this, you know, listening to what's happening in our community, staying informed. I gave you a quick, broad overview of what the activities are happening within our agency and our community. But tomorrow we should be having this week's situation report coming out, and Amelia will share those with all board members, so you can read that and get a more in-depth understanding of all the different activities. And of course, you know, again, taking the messages that you hear about respiratory etiquette and those types of things and sharing those with your those that you represent or the businesses that you work in. And then we always obviously want you to advocate for public health, looking at, you know, promoting continuity practices and preparedness practices within the businesses and the people that you work with, and supporting, again, all the daily public health activities that build resiliency in our community to keep people healthy. And then I hope that you will be able to take some time out to participate in different meetings that are happening, or exercises or trainings or planning processes, and really understanding how our community responds to incidents like this. And you know, this particular incident is more of a public health focus, but there's other incidences that will affect our entire community. And I know there was some recent changes with the city pulling out of the interlocal agreement that's happening with the county emergency management. So I understand there's going to be some future conversations about that happening, and so I hope you're involved in those conversations so we can figure out how we as a community will be able to work together and coordinate to be able to provide a real coordinated and efficient response to any type of incident that comes into our community. So next month, I believe it is in March, I'm invited to come back to give you a little bit more understanding and more education on response in our community and what our programs do, because there's a lot more to it, as far as your role in looking at, how do declarations of emergency work within our community, and what is your role in supporting those, and what are the different health officer authorities that may be instituted that you can support, and how does that work? So again, broad overview for you guys, and we'll see you again next month.
Don't leave.
Oh.
With the meetings that you were mentioning.
Could you use your microphone there, Mr. Hafner?
I believe, yeah, I don't know the specifics of when they're going to happen. I just I understood from the city and the county that those conversations still need to happen with the new administration to determine, again, because the city used to be part of that county emergency management process and response, and I'm not sure how that's going to look now when we have if we have a separate city and a county response. If we have two separate set of objectives, it may deter from having a common operating picture for how we respond. So.
Well, what I was thinking of is the fact that no matter, you don't know the time or anything, but that's all right. As long as we're informed it's going to happen, then we need to look at it and see if we can go.
Right, that'd be great. Thanks.
Thank you.
Councilmember Thompson?
So I had a question, first of all, on Dr. Lutz's presentation. You had a couple acronyms. I just wanted to confirm what they were. AWC, Association of Washington Cities, or something different? Okay, and then WASAC.
Mary, do you want to?
Washington State Association of Counties.
Oh, okay. I know a different WASAC, so I'm glad you clarified. Okay. All right. And then my other question was about, I've had citizens ask me about the spokesman review had the picture of the man standing at the helicopter when it came, didn't have any mask or anything on, and they're concerned that man could spread the virus by not having been gowned up. Do you remember seeing that? Does anybody know? How does that, what responsibility, or who's responsible for making sure that that person, any person, follows guidelines, or who sets the guidelines for when something, for that case? Type of situation.
Yeah, unfortunately, and the picture that you're referencing, Councilwoman, was sort of, the initial photograph that was taken was somewhat difficult to determine the actual distance. The guidelines for transporting those individuals were forwarded by CDC, and subsequent photographs that you saw the following day demonstrated that the individuals who were handling and working with that individual were again following guidelines. I think the important thing to put in perspective in hindsight is that this is a respiratory virus that's transmitted by respiratory droplets, i.e. coughing and sneezing. In this particular situation with the 4 individuals who were transported here, they were asymptomatic. So they are neither coughing nor sneezing. The guidelines are that in that situation, if you're not in PPE, then you are more than 6 feet from that individual. So again, looking at those 2 photographs, you'll see that the 2 AMR individuals who in full battle gear, in full PPE, whereas the others were an appropriate distance. It was difficult to tell from the first photograph, but subsequent photographs demonstrated that to be the case. I think the other thing that's unfortunate, and I've not seen these, but I heard this has been the case, is that there were some video and photographs taken of an exercise whereby you had some individuals who were with volunteer, slash acting active patients, and they were in PPE, but there were people, again, as part of the exercise who were not, who were sort of walking through. And so unfortunately, some community members have sort of conflated, because it's been misrepresented, that that was an exercise and not the real scenario. So, but again, those guidelines for handling of individuals is coming from CDC guidance. And again, I think that's something that the community needs to be aware of. We wouldn't have considered allowing these individuals into the community if we were not confident that all the systems were in place and all the processes were in place, and that the people knew what to do to handle the individual safely.
Well, and that's what I did tell them, and that we don't know the whole, just looking at a picture, you can't tell the whole story. But the perception of the public is extremely important in all these kinds of cases. And so I appreciate the education, the advocacy, but we still have to deal with the perception of the public, what's safe and not safe. until we can really get the word out and relieve fear. It's about fear.
And I think, again, to the Spokesman Review's credit, the writer of that article, she, again, the first image that was there, she got a lot of feedback from that. She reached out to us immediately, and, you know, I got a phone call. We contacted AMR, we contacted all of the agencies, and again, that was the clarifying piece that then the following day gave more photographs that truly demonstrated the way that the individual was cared for. Other questions? Yes, Dr. Kinley.
Have you heard that Bothell High School was closed today because they had a staff member whose family member became ill with international travel? And I was wondering if you'd talk to the health department over there, why if they simply had one person that was sick, they already closed the public high school. Because I've had patients ask, well, if we have somebody that's sick because of international travel and now we have them here, are we going to be facing the same thing? Since we alluded to how we have to make those decisions not in a vacuum, and it seemed to happen pretty quickly. Yeah. So I was wondering if you were aware of that.
I was not aware of it. Mark or Betsy, have you heard anything about that from DOH? No. Okay. I can't, but we'll definitely look into it. Yeah. Others? Commissioner
French? Or
I just want to follow up. One of the things you said, you made a comment, if we didn't feel comfortable that we could handle this, that we wouldn't have allowed these people to come here. What authority would the health district have weighed in if, say, that Providence didn't have that facility? But I mean, because from what I understand, the order to transport these individuals here came down from the federal government, correct?
It came from ASPR.
What role would the health district, hypothetically, if that quarantine unit did not exist at Providence, what could the health district have done to not allow those individuals to come here?
So they came to the states with a federal quarantine order. That had to be rescinded, and in doing so, they needed to have an isolation order put in place. That falls to the county health officer. And so if there was, again, concern on my part, based upon a lack of resources and or the processes were not in place, then I could have refused to issue an isolation order. The other thing is that, again, this was done in very close coordination and collaboration with ASPR, the Assistant Secretary of Preparedness and Response, in conjunction with DOH and with locals. And so, again, it really took that, and I have to, again, with the Special Pathogens Unit at Providence. So, again, you had three different levels of government, federal, state, and local, working closely with the Special Pathogens Unit. And if you may remember, a couple of years ago, we had Tranquil Terminus exercise, which was, again, simulating an Ebola case. Very, very different. A very, very different pathogen with a lot more virulence. Irrespective of that, the same processes were in place for this. And so, again, I think that the expertise that was demonstrated and continues to be demonstrated by Providence and all the, again, people and organizations supporting it, so AMR and fire and the airport. I think the confidence in all of those partners and the processes that are in place from my standpoint, and I think from the community standpoint, should reassure us that this was and continues to be a very safe operation and process.
Any other questions?
To go to see more what the messaging is for the public. It's like a take home, what they can do.
So, yeah, unfortunately, our communications person can't be here, but I did ask. And so we have a couple of different things, and again, I'll just sort of put this under 4 different categories. So the website, our current website, it's being updated almost on a daily basis. And so again, we're really looking right now at providing information and resources to the community, to different sectors, such as schools, employers, things of that sort. We also have a personal preparedness section that, again, you can get information for how you as a citizen can best prepare yourself. Monitoring social media. As you know, social media is the way that news gets out, whether it's true or false. And so really monitoring social media to ensure that we're in front of it and providing accurate information all the time. We've had plenty of media opportunities. And so again, from last week, we were constantly getting called. There was a request for us to show up at 06 tomorrow morning to answer social media feeds about questions for the community. And then again, working with community partners. So I see that Kelly has written, our PIO has written that there has been representation with K-12 schools, universities, government agencies, and working with healthcare entities throughout both this area and northern Idaho. And again, continuing to reach out on a regular basis on what we're doing and therefore what the communities and the sectors can be doing to prepare for it. And the 800 number. The 800 number for general questions. I don't know the number. Okay. There's an 800 number on the website. Okay, yeah. 800-1.
So I've been reading some literature lately, as this is a new virus, that they're looking at all the genetic coding, sequencing, et cetera. They've also been some discoveries of a particular spike protein, and that they're concerned it's going to switch from respiratory to respiratory fecal. Have you seen that at all in any of the literature that you've looked at so far?
So there were some concerns early on that, again, as you're suggesting, you could see this transfer. It has been noted that a small percentage of individuals have presented with GI symptoms. And so gastrointestinal symptoms, abdominal pain, nausea, and diarrhea. It's, again, speculative right now. I've not seen data that have suggested that we know that when we find specimen, or in this case it's PCR, polymerase chain reaction evidence of the virus in stool, that it is communicable. But again, I think, as you suggested, sir, I mean, this is novel and TBD. Mark, I'll look to you. Have you heard anything? Mark Springer is one of our senior epidemiologists, and he is on top of the science, so I always look to Mark and Betsy if nothing.
No, nothing more than you said.
Okay.
More question, just about the personal health, and I was just noticing on the chart how we reorganized, is health promotion been shut?
It's part of the community health.
Okay, so that was shifted over to that, okay. And I was just wondering about, on a preventive basis, what people could do, and that's what I was thinking about health promotion, about what an individual do to stay healthier so they're not as vulnerable. I don't know if there was any promotion on messaging on that at all.
I mean, I think with anything, and Dr. Lutzs weigh in, I mean, it's, I don't know if okay. Anything that you're doing to be healthier as a person with nutrition, with good hygiene, all of those things impact your ability to fight off illness or to not. And so I think, our healthy promotions programs are still going, and everything we do around nutrition and health are still out there. But we have not changed programming for the COVID.
Any further questions? Thank you, Dr. Lutzs. Now we're going to the legislative report.
Happy Bob.
Is this on? Good afternoon, everybody. Good to see you on this sunny day. I will keep this quick. Since I saw you last, a lot has happened. I took another trip to Olympia and advocated for public health. As we've heard, public health is essential when we're able to respond to outbreaks like this. I shared with our legislators information about how we serve their communities, whether it was meeting with representatives from the Valley or from Deer Park, just letting them know what kind of activities we do for them. I also shared a lot of information about vaping and what we're hearing from school administrators, especially about just their concerns trying to deal with this crisis in their schools. We are now 2/3 of the way done with the legislative session. We started with including the bills that carried over from last half of the biennium, there were 4,400 bills this session, and only 588 have made it past the cutoffs. So that's made it a lot easier to track the bills. And The next big deadline is tomorrow, and then there's the next big cutoff is tomorrow, and then the session is over in just a couple weeks. So this will be my last update during session for you. I'm still tracking a number of bills that would help fund foundational public health services, including at least one that would do so through a vapor tax. And you have this legislative highlights document in your folders, I think. Everything in here is currently not dead except for one that I included because it was an interesting bill and then it died. But you can take a look at what's in here, and if there are any specific questions, I am happy to try to answer them. Otherwise, I'll pass it off to the next people.
All right, any questions? Commissioner Kearns?
Which of our area legislators have you been able to meet with, and which have you been able to just meet with staff?
Oh my gosh, good question. And I can actually pull the list for you because I don't think I'm going to have it off the top of my head. But when I was there the second time, I met with, the first time I went, I met with mostly folks that we typically talk to. So Senator Billig and Marcus Riccelli, they're just our big advocates. The next time I went, I spoke with more folks like Mike Volz. We were able to meet with him one-on-one. And I'm going to have to pull the list for you to tell you who the other ones were because I can't remember right now.
Any other questions for legislative? All right, thank you.
Thank you.
On to our financial report.
All right, thank you. So, as promised, there was a couple of financial reports in your packet that got sent to you this month. There is the 2019 actual compared to the budget, and then there's the 2020 that goes into the January expenditures and revenues. Just a couple of highlights I'll highlight about these items. As you can see in the 2019 actual expenses, we were very close to our expenditure authority. That's the closest we've been in like the last 20 years there. So we did a good job of bringing that budget amendment to you the middle of last year and figuring out where we're going to land. As you look down into the revenues, so we actually were under on our expenses and we were collected more on our revenues. We were over on our revenues. So when you look at the combined total between the two, where we were projected, or the budget was to use $291,000 out of our reserves, we actually put $749,000 into our reserves. These numbers can change a little bit as Kim Kramars and I start to do the annual report, so there could be some fine tuning, but that's pretty darn close to where we're going to land for the year of 2019 actuals. So the other request that came along as far as on this page was, what does that do to our reserves? So as you can see, that 749 goes into our unassigned reserves as opposed to coming out of there. So where we have been talking the last couple of years that with the use of the reserves that we were scheduled to use in 19 and the reserves we're going to use in 20, it was dropping our percent of budget all the way down to about 15 or 16%. And so our goal was try to get that back up. Well, just by getting this up to the 749 into the reserves for the year that just ended, that actually gets us up to 19% of budget. So we're feeling pretty good about the number of trying to hold that near up that 20%, and there could be another budget amendment this year to possibly hold that at that or above. We still do have the committed reserves, the board emergency, the $1.5 million that we have out there, that we have to come to the board to ever use that in a dedicated emergency. And then we have the assigned reserves that are assigned reserves by the director of where we hold reserves out there for these particular items. The other one that was a new one that we're starting just this year is this is going to be a monthly report. So each month I'm going to come and then give you a report here. As we were working on this, I was working on this with the exec committee of the board along with our administrative officer, Amelia Clark, and we had come up with I'm going to run the reports on the 15th of the month every month. That way it stays consistent. So I ran the January report on February 15th. What happens at that point is most of our expenses are in there for the month of January. but all of our revenues aren't. And so as I plug in the January expenses, what it does on the bottom side, it makes it look like there's a need of dollars to balance out of the $1.5 million, but we don't have the grants built in there yet. So starting on about the 18th or 19th, our grants biller starts working on all the grants, gets those dollars, puts them in there. And so by the time it comes to next month, I believe what we'll do is work on this sheet where we're going to have those same January expenses at the top, but then the January revenues will have these grant billings in there to give you a more clear number of where January ended. And then we'll be in sort of the same situation in February where the expenses will be in there, but not the revenues at the time. So that's our goal right now as far as giving a monthly report each month. But I don't want people to panic when they see that number of the $1.5 million, because we still have plenty of grants to bill out for that month. And but also, if there is suggestions on the format, on the style, on other ways you want to look at some of the numbers, please let myself or the budget committee know, because I'll be working with them on those.
Commissioner Cooney?
So just to clarify,
Yeah.
that most of our, I think almost all of our grants are on a reimbursement basis, so we do have to have those expenditures occur first. Oh, sorry, I thought I turned it on. So we do have to have those expenditures occur first before we can seek the grant funds for the revenue
Yes.
side. So we are always going to be in arrears
Yes, until
in
we
that
get to the final
situation.
end of the year, yeah.
So just
Yes.
wanted to clarify.
Yep.
Thank you.
And then the other big change that happened was last month I brought you the procurement policy. And in the procurement policy, there is a rule that I have to come to the board on any contracts or purchases from one company, 100,000 or more. And so I am going to be working with the Budget and Finance Committee and the Exec Committee of the Board and Administrative Officer Clark on a sort of a calendar or a timing of when we need to bring each month some of these contracts to you. And so we can be very proactive, get that to the board so you can look at it, hopefully approve it, and then way before we get it started. So we're going to be working on that in the next couple of weeks. I did, just so you're aware, because I know somebody brought this up, was in the January vouchers, there was already a purchase of 100,000 or more, and that was, prior to me passing the condition that I had to bring them to the board, and that was for our Microsoft licenses. And so when that came through, I went and I tried to get it onto this month's consent agenda, but because we'd already had the exec committee of the board, I could not get it on this month. So you will probably see that one on next month, even though it's already happened. You'll probably see it on next month that I did get permission from the board on that item. So, yes?
So Mike, when we look on the 220 budget, on the Medicare and Medicaid expenses where we're 0.36, that's because we haven't received all the revenue from an expectation that Murray was talking about.
Yeah, that's actually just the corrections. At the end of the year, when it says that minus 201, that was actually corrections as we started off the year of taking ones that either weren't billable or the billable amount wasn't that amount. And so there's going to go to a positive number once we get all those Medicaid and Medicare billings done. That'll come up, that'll show up positive.
Can I just make a clarifying statement? I think Mike mentioned that the $100,000 grant, not grant, expense, the board, we wouldn't be seeking approval because it had already happened. But what we realized in going into this process is that for next year, like that's when our licenses for the computer system are due. So like the process would be that in December, at that December meeting, you would approve those. So I just
Correct.
wanted to make sure we were clear about that
Yes.
word for the minutes, that it's not, we wouldn't be like back approving, we would just be going forward, but we wanted you to be aware of it. With transparency and everything, that had happened right before the procurement policy went into effect. But then that's something that we'll have every year ongoing because it's our license.
Thank you.
If that
Sounds
makes
good.
sense, I hope.
Yeah. Thanks for the clarification. Any other discussion or comments on the financials? All right.
All right, thank you.
Thank you. Now for our upstream work and the determinants of health. Lydia.
Okay, good afternoon. Total change in subject. So in your packet, there are some handouts, and I'm just going to be referring to them, but I'm not going to go over them. One is a pretty complicated handout, looks like this. There is a glossary of terms, and then there is some program activities demonstrating upstream, downstream examples. So the idea of this presentation really is to kind of get everybody on the same page with how we talk about things. We've noticed even internally in our agency, we all aren't seeing what it means to be upstream or downstream the same. And so this presentation hopefully will kind of ground us in this language. I did give this presentation at a SNAP board meeting, and it seemed to really resonate with the board members. Karen Stratton was there and heard it already. That's probably why she decided not to come today, so she'd have to hear it twice. So the determinants of health. You've seen different charts that look like this, but from research, they really say that about 40%, and including the environment piece with another 10%, about 50% of our health is due to social, economic, environmental factors. So we always think genetics is the main thing that impacts our health, but it's also our demographics and where we live, our income, and our education. And they all relate to each other. So for example, if you genetically are disposed to asthma and you live in a low-income area that has very poor air, and you're low income and don't have access to resources, your health is much more likely to be poorer than somebody that lives in a very affluent area and has those same genetic disposition. So I'm going to just kind of demonstrate how this kind of all plays out. So this handout is very complicated, and I'm going to kind of break it down. To the left is the upstream, to the right is the downstream. This is across the life course from birth to death. It's showing a different framework or a different way to look at things that can impact life from birth to death. At the bottom of the handout, you'll see a blue strip, and it's the one that kind of defines what it means to work upstream, midstream, or downstream, and what are the strategies that are used to do that work. So we're going to break it down now. So the medical model, which is the right side, this is really about risk behaviors and status, disease outcomes, and the disparities that are within that. In that blue box, you can see our priorities for our strategic plan, and really it's the outcomes that those priorities are pointing to. We aren't doing very well in our community around behavioral health conditions, cardiovascular disease, and family violence and trauma. So we often focus on individual behavior in the medical model. We look at genetics, we look at access to care, and then we look at the outcomes and the disparity that happens because of those things. So typically what we do when we focus on the medical model is we use health education, counseling, preventive screenings, very direct service type of things. We often focus on populations that aren't doing as well. So those that are homeless or have mental illnesses, disabled. We really look at the disparity data that's often broken out by race, age, sex, and education and income. In my career here at the Health District, when I first started in health promotions, we were very individual focused. We did small work educational sessions, or we did brochures and fact sheets, and we were very much direct service driven. And when we realized that it doesn't have as great as impact is if you can reach more people. So that's where it started going more upstream and focusing on a different area. So the determinants of health, or the upstream framework, is really looking at social and institutional inequities and the conditions of health that surround us. So what are the barriers to those conditions? And what are those supportive environments that we need to be healthy? a good home, access to education, an ability to make good money to be able to support the resources that we need. So how do we do that work? It's really more system changes, policy changes, looking at the environment and doing cross-sector work. A lot of partnerships with people who, we don't do transportation, so we work with those that do transportation. Looking through an equity lens and really thinking through who are the people that can't access these conditions and how do we make it so that they can. So it's really a lot of non-direct service work, but more at a higher policy systems level. I was looking at the Board of Health policy agenda, and it's very much an upstream agenda. And it's really focusing on those conditions or supportive factors, what's the term? Protective factors, to make sure that our quality of life is high. So there's the model, but I want to give you a kind of a simpler way to think about it. Upstream is focused on inequities, things that are discriminatory or practices that limit who can access those conditions. And the downstream part of that is the disparities that come from those inequities. And we measure it in the data. So you can also think of upstream as the conditions that surround us, and the outcomes are the downstream piece. So we have upstream environments that create a quality of life that help us be healthy. And then we have the downstream health outcomes after we've experienced where we're living and how we're living. So this is a King County model, and I just wanted to show you some other models that people are using. You can see at the roots of the trees, it's all of those conditions that you saw previously. Affordable, safe, quality housing, access to health and human services, early childhood development, affordable food, and it's feeding that tree, and because those are going into the roots, that tree is growing and has a lot of health and life to it. So what they are showing here is that they're working on making sure that everybody has access to those things. On the left side, all those people are trying to get through and have a good life. And there's barriers, and some of them get through and some of them don't get through. And those that don't get through are oftentimes have those outcomes on the right side. On-time graduation is lower, wages are lower, an educated and skilled workforce is lower, quality affordable housing is lower, and we have higher health costs. We have health problems, we have crime or unfilled high-skilled jobs, incarceration. So how do we get everybody through to have a quality of life? So we remove the barriers and we work on those things that's limiting those people from all getting through and having that equal access to having that quality of life. If we can get more people through, like Bob's favorite saying, we're all better off when all of us are better off, then you're going to have lower healthcare costs, health problems, crime, unfilled high-skilled jobs, incarceration, and you'll have the higher on-time graduation, wages, an educated and skilled workforce, and quality affordable housing. And health outcomes will be better. So I'm going to show you one other way to do it, or look at it. This is from the Washington State Department of Health, and they focus a lot on the equity, diversity, and inclusion portion of the upstream model. They really look at social inequities and the racism or ageism or those that are disabled, and all of the biases that go into that prevent those individuals from having equal opportunities or equal access. There's a lot of inequities in our institutions. There's a lot of barriers that we set up for the people in our community. And a simple example is just we work 8 to 5. Well, for those that work, sometimes that does not work, where they need after hours or different times so that they can get to that service. Our community, we sometimes set up barriers just in how we set up our structure, and really needing to look at that and take a closer look of how these barriers are impacting the quality of life of the people in our community. So you can see some of the poor outcomes that they're demonstrating by this work. So how do we get everybody in Spokane County to have equal access or equal opportunities? And you really look at those inequities. What are those barriers? One of the examples I always talk about is if you were a single mom with a Section 8 voucher, how easy is it for you to get housing? And I know that the city and county have been working on that non-discriminatory practice of those that carry a Section 8 voucher. What is it that we need to do with working with landlords to get them to accept it? So that's a perfect example of kind of an inequity or an issue that's in our community that prevents that person from having stable, affordable housing. So we have choice points, and this is the work that our agency has been doing for 5 or so years now. And I would say we've come a long ways in understanding the upstream vision and looking at inequities. But it's really kind of talking through, how do we incorporate this equity upstream lens in our thinking? Who is it that has access to healthy living conditions, but who doesn't have access? And how do we make it so that it is more equitable? There's a PowerPoint that staff from Department of Health put together, and it just had some different ways to kind of think about things. And one of his examples was, a lot of times we talk about a group, like a board, and we ask, who isn't at the table? And the question that he thinks we should ask is, who is it that would like to be at the table and can't be at the table? And really getting those voices heard of those that are sometimes not able to give their perspective or opinion. So it's really thinking through how we look at things and really getting the voice of those that often we don't hear from. So this is just a simple framework to show that when you're working on systems and you're doing system change, which is very difficult. We all work in systems, the school system, the healthcare system, we have the public health system, and to create a system change, it takes a lot of work. And what they say with this kind of work is you have to start at the bottom of the mental model and really think through our own biases and our own way of thinking and try to shake that up and think about how we could do things differently. And I'll just give you a personal example of something that I learned in the HIV program. So we run a needle exchange, and I don't know, probably about 2 years ago, the staff came to me and said, we want to give out Narcan out of the needle exchange. And I'm like, why would we do that? You know, and I didn't understand. I didn't understand, you know, the whole purpose behind it and the ability of what Narcan could do. And after they educated me and I started thinking about it and I started hearing about it, it was like, yeah, that's what we should be doing. But it was my own mental model that was holding a lot of biases around us providing that service out of our needle exchange. So until we change our own thinking, and that's a lot of what the equity work is about, is changing our own thinking, then we start to understand what do we need to do in a system to make changes so that we can actually improve health or do things differently. So this is a framework by Human Impacts Partners that we've been using, and I just want to recognize 2 of the staff that is really doing this health equity work in our agency, Helene Dewey and Rowena Pineda. They have been really training staff, providing support, moving us in different directions in our agency to really work on equity issues. And like I said, we have come a long ways in our own organization. But what they say is you first have to really look at your own agency and the biases and the things that you hold before you can work on other things to further equity work. This framework really talks about your internal infrastructure, cross-sector work in other government organizations, partnerships, and really being champions of this. And so, of course, we're hoping the Board of Health will be our champion also to further this equity work. I also want to recognize that Rowena is leaving us, and we are going to definitely miss her, but she's going to the United Way. And she is going to carry this work further at the United Way, and we know that we will continue to work with her, see her, and but we're going to miss her. So just a few more examples. I wanted to kind of translate this kind of theory to program work and show you kind of how it plays out. So if you look at the orange box on the right side, that's the medical model. So the HIV program is something I'm very familiar with, so I always give that kind of as my first example. But if clients are unable to adhere to their treatment, their disease will progress, they will remain infectious, and their illness and mortality will be higher. HIV rates will continue to go up. So if you look at the upstream model, you can see that HIV clients have had a lot of stigma and biases against them. Landlords, even to this day, are unwilling sometimes to rent to them. And we have a lot of clients that used to be homeless. When we took over the SAN clients, we had about 70 homeless clients. Well, you can imagine if you're homeless, how are you going to adhere to your medicine? How are you going to get to your healthcare provider? So the system has really changed in the state where they have given us funds to work on housing. We have a housing coordinator now, and we can provide transportation. We have an electric vehicle. But the system really had to change so that we could do that work. We work on non-discriminatory policies, societal changes, the conditions that support people in the upstream model. To do this for the HIV program, we're modernizing the HIV law and helping with that stigma piece and those biases that are against people with HIV. We do a lot of education with landlords. We are now transporting people to their appointments. So what happens? Individuals can adhere to their treatment, their disease is controlled, and they're not infectious, and we have longevity and HIV rates decrease. So the right side was that medical model. That's where we used to always really focus, and now we've moved more to the left, or that upstream model, and it will improve the downstream. We still have to do both. We can't just do one or the other. We still need to do the direct service work, but also we know that the upstream is really helping the system and us take care of these individuals. So another example, here's one that's our strategic plan priority, family violence and trauma. You can see on the right, family violence, trauma and injury, illness and mortality. We know that there are biases and racism and sexism against women. You know, if you can think of your own thoughts of child abuse, domestic violence, sexual assault, and the biases that you may hold in your head when you think of people that are either victims or perpetrators, and how that plays out in your mind. Domestic violence and abuse report handling isn't always done very trauma-informed or helpful. A lot of times women and even the victims and perpetrators experience discrimination. They feel unsafe. They don't feel like they have social support. So if we really look at the discriminatory practices, the upstream societal changes in laws and conditions, we can create a safe and responsive environment through policies and system changes. we can develop a positive social network for families and really have a trauma-informed environment so that we treat all people with respect and dignity. And if we do that, we're hoping that family resiliency and recovery will go up. Whoop. And the rest. So translation to program work for cardiovascular disease. Just one more example, and then we can take some questions. So on the right, poor nutrition, low activity, depression, stress. We have a lot of disease and injury because of that. We have disparities in illness and death. And we know that there is classism, racism, ageism. Our communities are often segregated. In a low business investment area, there may not be good access to fruits and vegetables. Or there's an infrastructure where there's no sidewalks or lighting or transportation. And because of that, we have food and housing insecurity. People have a hard time being physically active and feeling safe or having a place to run or walk. And so those issues on the right just continue to increase. So we use a health in all policies framework and an equity lens, really thinking through what do we need to do different so that all people have access to nutrition, have access to the ability to physically be active. And we develop opportunities to access fresh fruits and vegetables. But it's a system of access. It's not individual. And it's a walkability for all of our residents. We're investing in low-income neighborhoods. And I know with the city and the county, that's what we're doing now, where we've really improved, the Sprague Street, or we've really done some investment in the Monroe Street and really looked at complete streets and that type of thing. Because of that, we'll have better access to nutrition and physical activity, and our stress and depression will go down. So that was it. So questions?
Questions on the board? Councilmember Thompson?
Well, this is so timely. I appreciate this work so much. And yesterday I was talking to somebody who knows she's going to be homeless in a year. She's a veteran on a very small stipend or retirement. She's disability retirement. She lives in, I'm not sure what the acronym is now, but Section 8 housing. Mm-hmm. And her rent just went up $30, and it's going to go up $70 next year, and she cannot afford that. So she's going to stop eating. She's going to, whatever she's going to do to save the money. And I'm just like, this system is overwhelming to try and figure out where to even go to help. And so, and we've worked on this for years. I mean, we've worked on it for years and years, and this is a great way to put it up and show it. But how do we look at the improvements? Do we have any statistic? Do we have any successes where we can say, in this neighborhood, we have raised the life expectancy by 5 years by doing this, this, and this? A lot of times, folks will need proof.
Yeah.
Because you can talk about equity, you can talk about better health, you can talk about how housing affects somebody, but what do we have to show proof that, I mean, there's research, I know, but I'm just overwhelmed with even like where to start with her.
So,
and everybody.
One example is the Odds Against Tomorrow report, where we looked at place-based longevity and the income differences and the health differences between the lowest income and the highest income neighborhood. So I know that the data center is committed to continuing updating that information and data. As we know, it takes a long time to show it in the data, but we are looking at different ways that we can measure it.
If I may, I'll reference there's an economist who has done some really phenomenal work. It was first reported in the New York Times, and I'm excited about the fact that we're going to be able to bring a couple of the researchers from Seattle who are involved in it. It's called, and again, it's maybe Project Opportunity. Again, I'll get the information for you. But what's interesting is that what they've shown is they've taken low-income families and moved them to different neighborhoods. and higher income neighborhoods with more resources, and specifically focusing on youth. And what they've demonstrated is that in these couple of examples, and Seattle is the closest one, they move families with young children, and the health outcomes as well as the economic outcomes for the children and families are improved. So we're actually in the Anovia Foundation and some WSU researchers, and we are supporting a couple of the people from Seattle to come over in March to talk about the work that they're doing and look at how that could be played out in neighborhood or neighborhoods across the area. So as I get more information and as it gets finalized, I'll pass that on. But it's exciting because, again, it shows that, and we're not talking about 20, 30 years. I mean, we're talking about children having better outcomes within 5, 7, 10 years. But the caveat is that you have to do it early. Because one of the interesting findings is that if it were the improvement was better seen in elementary school children than when they got to middle school and high school. So the longer the exposure, the better the health outcomes and economic outcomes.
Mr. Hafner, do you have something?
I just wanted to say a good report,
Good?
and I think it was a very, the explanation that you gave was clear for us, so thank you.
Thank you.
Ms. Ross?
The one handout that is, it's just a one-pager, does give you some program examples of things that we are doing, and it shows the upstream, downstream. And even in doing this, it was really helpful for me to kind of think through how to place those. And like I said, we have to be doing both sides, but we do want to move our programs to really think more around systems and policies.
Yeah, and thank you for the report. But I kind of have a specific question that just kind of perked my. You talked about the HIV. How would a landlord know if somebody had HIV when they can't ask those questions? And then just kind of could talk more about that. And
Sure. So the landlords are working with our program, and so they know that we are trying to place our clients so that they do know that that's where they're coming from. Sometimes the clients themselves will disclose it.
Like this, I can't say it right. So for that reason, they won't sign a lease with them.
Sometimes, yes. But we have a housing coordinator now that works, she's awesome. She works extensively with landlords and prevents evictions and helps, people stay in their homes. And she's the one that really is able to advocate for them and to get them housed.
Sounds good.
Okay.
Curious.
And when you talk about partnerships, I mean, I look at the VA and I think their retirement or their disability pensions do not go up while everything else goes up. And in this case, this person doesn't want to work, doesn't want to do anything because she's been told she'll lose her disability pension if she does anything to upset that. And so those partnerships are critical because, she might be living with me next year.
Yeah.
I don't know. I'm just
Yeah.
like, what are we going to do here? I mean, and that's just one person in one day that I talked to. And so.
Right. And I think that is an area of a law or a policy piece that we should really look at as a nation. We've heard a lot of stories about, disability and SSI, and if they make too much money, they get kicked off, but they can't make enough to, live. So.
Okay. All right, thank you. I don't believe we have anything for an executive session. Oh, we do? Okay. All right, I guess we will adjourn into executive session for 10 minutes for pending potential litigation. We are back from executive session at 2:13. Next, we have board member check-in. Ms. Frostad, you want to start us off? Commissioner? We're a quiet group today. No check-ins all around. We don't have any more citizen input. So just note that our next regular Board of Health meeting will be March 26th. And at that, I'll look for a motion for adjournment.
Second.
All those in favor, please signify by saying aye. Aye. All those opposed, nay. We are adjourned. Thank you.